times in my life I've lost a lot of weight and kind of too much, because then that other thing happens where I'd kind of get control of the eating, and it feels good in that sort of, you feel a bit high with the kind of semi-starvation. So at times I would swing between overweight and underweight, and there was never a sort of steady thing. And of course, it was kind of shameful, really, as a psychologist, to not have control of this behavior, because that's what psychology is all about, is trying to understand behavior. And
Today, my guest is Dr. Jen Unwin. She is a clinical health psychologist. She's a past chair of the UK Association for Solution Focused Practice. She is the winner of the British Psychological Society Karen Ellard Lifetime Achievement Award in Clinical Health Psychology, and she is the co-founder of Food Addiction Solutions. Dr. Jen Unwin has spent her professional life interested in the role of hope in chronic disease and how it can be used to bring about behavior change. Her insights teamed up perfectly with Dr. David Unwin's interests in bringing about drug-free type 2 diabetes remission. For over 13 years, they have been running group sessions in primary care to achieve just that. Both doctors were featured in a BBC TV documentary, The Truth About Carbs, that was seen by 3.7 million viewers. Jen has written a book that I have read that's very good. It's called A Fork in the Road. And she is part of the team that published the first ever treatment study in the field and coordinated an international expert consensus on food addiction. She is truly amazing. And I just want to point out that Dr. Jen mentions a lot of resources and ways to support the movement in getting food addiction recognized, and as well as ways to support food addiction solutions. So I'm including all those links, so make sure to check out the episode description. And without further ado, here is my conversation with Dr. Jen Unwin. Dr. Unwin, can I call you Jen on this podcast?
of course.
Okay, Jen, it is so wonderful to have you here on the Beyond Binge Eating podcast today. Thank you so much, and I'm excited for our chat.
I'm so happy. It's my favorite thing to chat about. Look, all the things we're going to chat about. And I love the stuff that you do in addition, that I don't do so much, but really enjoy partaking in the mindfulness stuff and the embodiment stuff. I think it's really important. So yeah, I can't wait just to chat on. You'll never get rid of me now.
I love it. Wonderful. Okay, well, I guess let's start. I do want to hear your personal story, but I think because I guess I've just become more aware of you in the past couple of years, and so I didn't know about like all the years of your life before that, that actually food addiction wasn't a central focus, that you actually really focused on hope. And that
Yeah.
was really interesting and surprising to me that you've spent your career focusing on hope. And that's been something that's really been close to my heart as someone who's wrestled with that in recovery. And I just want to hear a little bit more about your interest in hope, how you researched it, and then also, like, do you feel like that connects, like, are there threads that connects to what you're doing right now?
Yes, it was like my whole career was kind of preparing me for this work in food addiction without me knowing. Um, Obviously, was super interested in loads of different things all through the way, but yeah, the hope stuff really was a big sort of aha moment. And I got a little bit. I'm one of those people, maybe it's the addict brain, where if I'm get into a thing, I'm really interested in it. I'm thinking about it and how to simplify it and how to explain it to other people, and how you would apply it to make people's lives um better, really, and to help them maybe do something different, or see things another way. So the way that came about, yeah, so I'm a clinical psychologist by background, but I'd always worked. It was kind of unusual at the time to work in physical health settings. So although when you train, obviously you do mental health, older people, people with learning disabilities, children, we kind of train to do all of that, and then you can specialize. I specialized in working in, you know, so I spent quite a bit of time working in big tertiary hospitals with people with physical health challenges, life-limiting conditions, disfigurement, chronic pain, all of that kind of stuff, and how you help people to live the best life that they can with whatever those restrictions are, physically or mentally. And I kind of, you kind of try to do it the traditional way, the way that we'd all been trained, which was kind of at the time, behavioral stuff. CBT was a big thing. Not so much at that time in the UK, not so much the sort of psychotherapy type stuff. And actually, in a big fast-paced hospital, that isn't a model that fits anyway, because you're talking to people by the bedside, you're seeing them in clinic maybe, but maybe they live 40, 50 miles away. So they're not, you don't get to see people very often. So you needed something that was going to fit. I think the other thing that I noticed was that, yes, people struggled, and some people really got very, very stuck and, really were having a hard time. But I think I think it's like when you work in medicine or psychology, you think everybody struggles or everybody has a difficult time. Working in a big hospital, you saw that thousands of people came through that hospital who'd had traumas or were sick or other, whatever the challenges were. And the majority of them did okay. Nobody was having fun, so it's not that, but people, human beings find a way to incorporate things in their lives and to sort of move forward. And so I started to get interested in this field of positive psychology, which is Martin Seligman's thing. And that had all, there'd been quite a lot of research going on because this would be back in the 80s and 90s, which is about human flourishing. So it doesn't start from the question of why do people get depressed? What makes people, why do people get PTSD? Why, it starts from the question of, why do some people really flourish, or why do some people manage to adjust to very difficult circumstances, but in a sort of positive way, and find, people even find benefits. And I saw that in the hospital, people who would eventually say, I'm so glad this happened to me because it made me reevaluate everything, and this is better and that's better, so I started getting really interested in positive psychology. And what happened in separate thread is that when I trained as a clinical psychologist, what we got was a master's degree. And then very soon after that, the year after I qualified, or 2 years after, it became a doctoral degree. When you qualified, you got a doctorate. And so of course I wasn't going to settle for that, having a master's. So I thought, right, I've got to do my doctorate now. What am I going to do it on? And I was thinking about all these ideas at the time. And I thought, at the time I was working with there was a centre there which was kind of about rehabilitation and mobility and orthopedics, and they did a lot of lower limbs amputations for people who, I mean, usually actually ironically it was diabetes and things that would cause people to have a lower part of their limb removed, although sometimes obviously accidents and other conditions. So I thought, right, I'm going to look at what are the factors that predict who's going to do well. So we were not looking for like who's how many people who have their lower limbs removed get anxiety and depression, which would be the traditional way of looking at it. It was of these people who are going to have a limb removed in a planned way, so like prospective study, measure loads of stuff, and what is it that predicts who does okay or better, who adjusts to this challenge, and who does the rehab and has says that their quality of life is, rated higher, or their mental well-being or whatever. So that was the idea. So I looked at loads of stuff, and the thing that I was particularly interested in and included in the study, as well as, loads of other factors, was this idea of hopefulness as a sort of character trait, really. And it came from the work of this guy called Schneider, who's an American guy. He's not around anymore, but he wrote some brilliant papers on this idea. And that actually you can concept. I think hope sounds a bit fairy dairy to people, doesn't it? They're like, oh, hope, yeah, that's lovely, isn't it? But it's a bit like motherhood and apple pie. Like, how do you get more of it? But he conceptualized it in such a lovely, simple way, and he had all the research around it. That you can explain it to other people and you can make sense of it. And also, I'll talk about in a minute how therapeutically what you can do is help people who hope less or lacking in a sense of a sort of positive future. You can help them with some quite easy techniques to feel more positive and more hopeful. So yeah, so it was this little kind of simple measure of hope, and that was the thing that explained most of the variance in the data and in the outcomes for people. So it wasn't the seriousness of the operation or gender or age or any of those sort of traditional things that we think might be related to outcomes. It was this variable hope, which is wonderful and fantastic. And of course, people don't get. It's like the art of medicine, David. So my husband's a general practitioner in the UK, so obviously we talked about this stuff a lot, and we were sort of saying it's like the art of medicine, really, because hope makes such a difference in all kinds of conditions like cancer. I mean, even end of life care. It relates to a range of hard outcomes, like how much medication people take, how much
Wow.
pain they experience, even mortality, like all-cause mortality. There was a big study by Long and colleagues, and all-cause mortality is yeah, it's highly related to how hopeful people are. And they did a massive study. I can't remember how many. It was thousands of people in this big study, and it again prospectively, so people were followed up, and
Yeah.
yeah, even mortality is kind of related to, do you have a sense of, so hope is three main components really. Do you have a sense of a preferred future or a sort of hoped for future that's better?
Hmm.
Do you Can you see the steps that you might take? There's a kind of path that you might follow to get there. And thirdly, do you think that you have the confidence and the motivation to follow those steps? So you could have two out of three of those things, but it's not going to work. So you could, like some people can really imagine, oh, it'll be really, this is a something I'd like to do or experience, or a place I'd like to get to, and I can kind of see the steps to get there, but they don't have the self-confidence or the motivation to follow the steps. Or you could have loads of motivation and no idea which steps to take.
Hmm.
And
Hmm.
of course, some people really even struggle to think. A lot of patients that we see really struggle with that question of what better would look like, because they've got so hopeless and helpless that they've stopped thinking about better because they've kind of given up on that. And also, as medical professionals, I used to ask, so that was the first thing I always asked patients when they came in, and they're so surprised because medical professionals, psychologists have never never asked them what it is that they're hoping for, for
Hmm.
coming to the appointment, what success is going to look like essentially for them. They're like, well, I have never been asked that. That's part of the power of those kinds of questions, because it people have to really think about they have to really think about that question. Um and so I'm blathering on. Shall I carry on? I can carry on. I can
I love
carry
that. No, I love that. Just how hope is can really transform someone, and even to know that it's related to mortality is fascinating. And then those
on.
questions that you were offering of, do you have do you have a vision for a preferred future? And, what are some small steps that could get you there? Those sound like absolutely really supportive questions to help people go from what could be like, there's no way, how do I go from point A to point, Y? Like there's such a big gap, but
Very
like those
far.
questions really facilitate, like a positive vision and like just kind of trying to brainstorm, what is A, B, C, and D? And maybe it's possible that I can do that.
Yeah. And so I got super interested and went and trained in this approach called solution focused brief therapy. I don't know if you've heard of it. Some people will have heard
Hmm.
of it. But philosophically, it really aligns to this idea of hope.
Hmm.
Because in solution focused brief therapy, you always start with why is the person come to see you? What would better look like? What's their
Right.
preferred future? And you know, you never assume that you've got an idea of what a good outcome will be for them, you know, and then
Yeah.
you both get on the same page of trying to work towards something that they really want to work towards, rather than what you think is
Right.
a good outcome. So that's the first principle really, and the other is, well, what's already working, um
Hmm.
and drilling down into like, you know, there's always exceptions in people. So even somebody with, let's say, somebody with really severe chronic pain, there's always exceptions when they have a slightly, you have to be careful how you ask this stuff because you want it to be very respectful, but there's always times when they're either less aware of the pain or it's slightly better. So trying to
Hmm.
kind of
Hmm.
explore, like, when is the pain less, you know, kind of at the forefront, or you know, you're able for a moment to sort of forget about it. And you always get these lovely examples of, you know, it's when the grandkids come round, or you know, when I'm doing my sewing, or you know, whatever it is that allows
Hmm.
somebody to sort of get engaged in something that's more positive. And you know, what are their character strengths that have got them this far, and who's around
Hmm.
supporting them. And you can kind
Yeah.
of, those kinds of conversations then give people a sense that they're not starting from rock bottom. So you did
Yeah.
this brilliant scale, and there's a lot of scaling in solution focused therapy, and it's sort of, okay, well, like, you know, if your preferred vision is 10 out of 10, and 0 out of 10 is where, you know, none of that is happening ever, ever, ever. And because you've already had this conversation about what's actually already working, you know, they hardly ever say zero. Some people do, but they hardly ever say zero. And then you can say, right, well, you know, you've talked about the grandkids, and the fact that you try and go for a walk every day, and whatever, and your husband's really supportive, or whatever else it is, you know, where are you now out of 10? And it's always interesting because most people say 3. But you know, you get different answers, but I don't know why. Psychologically, people often say 3, and I think that sort of gives the idea that, yeah, you know, there's still a long way to go, but you know, there is some stuff that's keeping them off the bottom. So you're already starting with, you know, you're asking about a positive future, you're asking about what's working, and that's a really good foundation to then say, you know, what would 4 look like? It's really important not to say, how are you going to get to 4, or what would you do to get
Hmm.
to 4? Or I think you should do this to get to, you know, what if you came back next time and you were able to say 4, what would be different? And then they say like, well, you know, I might, I don't know, I'm trying to think of an example. I I'd go walk every day, or I'd notice myself less sleepy in the afternoon, or you know, whatever it is they come up with, and get them to just sort of describe that. And then, without having to sort of give people advice, which, let's face it, doesn't really work. Give people homework, doesn't often work. Tell them what to do. You know, it's just this exploration of the person's expertise, the person's best wishes, you know, the person's own motivations. So you get out of their way, and you just go, oh God, that's interesting. You know, I'll be interested to hear how, you know, how things are next time, and what you notice. And when they come back next time, you say, you know, what's been better since we last met. So it's this kind of relentless pursuit, not in a Pollyanna-ish way about, oh, everything's fine and fairy
Hmm.
dairy,
Hmm.
um, but sort of shining the headlights on when things are going a little bit better. Why did that happen?
Hmm.
You know, oh, you know, you did that and then this happened. Oh, that's so interesting, you know. And yeah, as human beings, we tend to drift to the negative. I think there's loads of research on that, isn't there? And that's why mindfulness and this kind of stuff
Hmm.
is good, because you
Yeah.
notice that you're doing that. I think
Right.
naturally we're very threat aware, so our brains tend to chew on stuff in a negative way
Hmm.
naturally. So I see solution focused approach as sort of almost like correcting that, and then teaching people a series of questions that they can ask themselves,
Hmm.
um, to stop that stop that slide into negativity, and noticing when things are bad. So you're encouraging people to notice, you know, when there's a little glimmer of something more
Hmm.
positive, and what was it about that situation that led to it being, you know, why was that a better day? Or, why was I less aware of the pain at that time? What was I doing? Can I do more of that? So it's very positively framed. And it sat really well working in that fast-paced hospital environment because you could just
Mhm.
ask some really kind of killer questions and and get a sense of how hopeful people were or not. And then, as I say, oftentimes, probably 60, 70, 80% of people don't actually need to see a psychologist. There's only
Mhm.
that smaller proportion actually who really needed those kinds of conversations to get their head around whatever challenges were going on.
And so take us back in time to food addiction, sort of, what was it about your history that inspired the passion that you have right now?
Yeah. So, I mean, I was like many of us, I don't remember a time when I wasn't super keen on sugar, carbohydrates. I remember
Uh-huh.
as a little kid, if I had pocket money, I was on my bike down the sweet shop with my best
Hmm.
mate. I mean, that was fairly normal, I suppose, but I was pretty obsessed with it. Um, one of my earliest memories, and I must have been only 4 or 5 because we moved house kind of just after that. We used to go to Sunday school, and we went to Sunday school and made cheese scones. I don't know if you have those in this, just like a kind of cheesy muffin, nice and warm,
Hmm.
and with I brought them home on a plate. And I had a tantrum because I was told they weren't all for me. I'd assumed because I'd made them, I was going to eat them all. So yeah, so that kind of stuck in my mind. Yeah, so that was the beginning of it really. And then there was a couple of kind of difficult things, family things. So my dad's brother died in an accident, like really suddenly, tragically. He was a young man. He'd gone to be a flying doctor in Zambia. Um, and so that was incredibly difficult, for
Hmm.
my dad particularly. And then my dad got ill himself. He was diagnosed with a cancer. So there was a lot of sort of difficulty for my parents, and then they were sort of absent, understandably, because they were kind of dealing with what they had to do.
Hmm. Hmm.
So I would stave off, I suppose, boredom, but also probably, a little bit of loneliness and uh, other emotions by scrabbling around in the kitchen trying to find delicious things to eat and making baking and concoctions. And so I think, like many of us, I used sugar and flour and anything else I could lay my hands on as
Hmm.
a kind of comfort. And then I got to senior school, so you'd be about 12 in the UK. And I was pretty overweight by then because of all that. And that was unusual at the time. So I'm 62 now. When I was at school, there was hardly anyone overweight. So yeah, I think these days I would have just basically looked a little bit tubby. In those days, I was really aware of it. And so that went on for most of high school. And then, of course, you get super aware of it. And I was at a girls' school, so there's a lot of diet culture
Hmm.
coming in at that time.
Yeah.
Also, my dear mum was for sure a food. When I look back now, like at her behaviors and also she did a lot of serial dieting. So as a teenager, I was roped in to some of the crazy diets, bless her, like kind of these awful things that people remember, like a grapefruit and egg diet. And
Hmm. Hmm.
there was another one that had a lot of yogurt and low-fat yogurt and celery in it. I remember. I still can't eat celery because such bad memories. But of course, you can't live like that. So it would only go on for a few weeks, and then
Hmm.
all hell would break loose.
Yeah.
And she was the same. So, uh, but I did. I at times in my life I've lost a lot of weight and kind of too much, because then that other thing happens where I'd kind of get control of the eating, and it feels good in that sort of, you feel a bit high with the kind of semi-starvation. So at times I would swing between overweight and underweight, and there was never like a a sort of steady thing. And of course, it was kind of shameful, really, as a psychologist to not have control of this behavior, because
Mm-hmm.
that's what psychology is all about, is trying to understand behavior. And
Mm-hmm.
um, as ludicrous as it sounds, it took me to the age of so I discovered low carb uh, about I was 48 or 49, so it took me all
Mm-hmm.
that time. And I found this little book called Escape the Diet Trap by John Briffer, who's also a British GP, and it explained all about insulin and carbohydrate. And I thought, this is brilliant. I'm going to try this, like the latest, because I'd done everything else, Slimming World, or
Mm-hmm.
what's the next scheme? What's going to be the
Yeah.
scheme that finally works?
Mm-hmm.
Right, I'll try this low carb thing. And I mean, that was actually brilliant. I thought it was, I felt so much better. Um, and of course, like most people, I'd been eating quite a high carbohydrate diet, low fat, that was the idea, wasn't it?
Mm-hmm.
So that was pretty good, and that worked for a while until, of course, you start doing the old keto baking and the old the old
Mm-hmm.
almond flour
Right.
um, sweeteners and coconut oil trick. And then the absolute eureka moment was when I heard Bitten Johnson talking on the Diet Doctor website. There was a video. She was talking about sugar addiction. And I mean, it was just like literally the cogs whirring. I was thinking, why have I never thought of that? It's ridiculous that I've never thought of it like that through that lens. Because
Yeah.
obviously, you know about addiction. Well, most people know about addiction in some
Mm-hmm.
form. I'd worked with people with other forms of addiction, like, dang. But all my behaviors and the whole history was just me trying to control something I couldn't control, which was my relationship with sugar and refined
Yeah.
grains. And so clunk, click. And then I thought, oh, right, okay, that's good. So I understand, from that, I understand that abstinence from those things is the treatment. It's not just about a
Mm-hmm.
diet for a
Right.
while. It's really right. I kind of get that now. And then um, I was lucky enough to be able to retire from the NHS after 32 years at the age of 55. And I thought, right, this is what I'm interested in now. And I went and trained with Bitten Johnson. And Heidi Yaver, that I work really closely with now, who's a nutritionist, just happened to be in the same cohort as me. Actually, it was because of me, because I said to her, why don't you do this course? Because I'd met her a couple of times, and she seemed interested. So, but after that, we just continued working together. So, yeah, that was the real turning point. Seeing Bitten's video, and then doing her training, and
Mm-hmm.
having the time then to
The
develop
HMA training, or was it a different one back then?
Bitten's. Yeah, it
Okay.
was called Ham at the time, but now she's changed it
Um,
around.
okay. Now it's
Okay, so
Ma.
she changed the letters around. Um, and throughout my career, I'd also had a couple of academic jobs, because I've always kind of spanned this between clinical and academic.
Mm-hmm.
So I worked at Manchester and Liverpool unis, training other clinical psychologists, but also doing research and lecturing and so on. So um, this is where I was kind of saying everything had sort of prepared me for coming in to do this work with food addiction, because I had the kind of model about a language of how you can talk to people about behavior change.
Mm-hmm.
I understood the addiction piece. Um, and also I had this sort of academic background where I could bring that into sort of, firstly kind of looking at what is the evidence for food addiction and how you might treat it, and then doing some research around that and some other research and papers that we've kind of got into. Um, and then in the meantime, David and I did a project where he was kind of getting so dispirited about the fact that all his patients were getting sicker and sicker, however many tablets he put them on with diabetes and obesity and so on. So we decided to start running a pilot kind of low carb group for people with pre-diabetes in his practice. And that was incredibly successful. And we've expanded it since, obviously, people with type 2 diabetes and other conditions as well. And so
Hmm.
he continues to do that. And we've written up a lot of papers on how that went. And I think he was telling me the other day he's got another case of, I think he's got 100, nearly 160 anyway, cases of drug-free diabetes remission, just by
Wow.
getting people
Yeah.
to cut out sugar and refined carbohydrates from their
Hmm.
diets, essentially. Um, yeah, so that's been really fun. And through that we got to go around the world speaking about that. So I started slipping in stuff about food addiction,
Hmm. Hmm.
speaking about that instead. So now he speaks about that, and I tend to speak about food addiction.
Yeah, and now, I mean, getting food addiction recognized is is it fair to say that's your life, that's like one of your life's missions right now?
Yeah, yeah. So I will die happy if food addiction becomes a recognized um disorder, which is, I was thinking about it before. I was thinking it's ironic really, because as a psychologist I used to sort of sort of speak against the classification of
Mm,
mental health problems, because
yeah.
it's a massive oversimplification. And when you
Hmm.
label people, there's problems with that on there. There's loads of
Hmm.
problems with with the DSM and in terms of sort of mental disorders. But then, yeah, the irony. So here I am campaigning that the ICD and the DSM recognize ultra processed food use disorder, or
Hmm.
going to call it as a condition. Um,
Hmm.
and the way that I justify that is, I think until there's that official recognition, there won't be the money for research, because that's how it tends to flow.
Yep.
Um, but more importantly than that, there won't be the money for interventions for people for help. So
Hmm.
if you go to your doctor now, in the UK, but I'm sure it's the same in the States, if you went to your family doctor and said you had a food addiction or a sugar addiction, they just would not know what to do with you, because there isn't a service to refer people. There isn't a classification that they can kind
Right.
of tick the box. There aren't approved medications, if that was the way that it seemed it seemed a helpful way to go. So um, yeah. So if you've lost control of gambling, alcohol, nicotine, any kind of drug, this even like pornography, there's places people can go,
Yeah.
um because they're all recognized as addictions.
Right. Right. It's super important. So it seems to me that in the past couple of years, there's been a lot of progress towards
Yeah.
achieving this goal of recognition. I'm wondering if you could provide just like a brief rundown of what the efforts and achievements have been these past couple of years, including the food addiction conference, the Delphi paper, other things that we might not be aware of. Can you just share some of the highlights from recent history? Because it seems like you are doing big things, Jen.
Yeah, yeah. So I mean, all credit to Heidi with this. Like, so Heidi is a person. She had a high-flying international career um, before she had her own story, and has started focusing on this work. So she's one of those people who doesn't really kind of think, oh, that won't be possible. She just thinks,
Yeah.
oh, well, I'll go. So Bitten Johnson was part of the Food Addiction Institute, and she'd
Mhm.
one of her tasks was to find out from the ICD, how you might apply to get a new condition sort of recognized. But that wasn't playing to Bitten's strengths at all. And she
Mhm.
says that herself. She said, like, there was no way I was gonna do that. So Heidi's like, oh well, we'll do it. I'll do it. So she went in there and found out how it is that you do it, and there's this kind of platform you make an application to. So in 2022 we put in the first application, um with justification. I think we had about 200 research papers at that time that we all collated. Molly Penchab was part of that, and Zippy Livney as well. Trying to find all the papers and sort of the ones that were really relevant, and put them in
Mhm.
summarized and everything. So we put that in. I think we waited I think it was just over 6 months, might have been 9 months, something like that,
Mm-hmm.
um, for a reply. And to be honest, we weren't that hopeful about it being positive because, you know, it was there wasn't masses of evidence. So
Yeah.
um, then we got the reply, and it was a no, but that was fine because of course, they have to say why no.
Mm-hmm.
So then you get the kind of why no, and you can start focusing on that. So let me try and remember what the why no's were. So number one was that there is no consensus about this condition. So that was
Mm-hmm.
number one. No. Number two was that the conditions the symptoms are fully explained by categories that are already in the ICD, and by which they meant eating disorders and food and obesity.
Mm-hmm. Yeah.
So that was that. The third one was that there was no um, outcome research, which was fair point at the time.
Mm-hmm.
Um, and the last one, which is not fair point and which kind of made us laugh, was that it would cause confusion.
Mm.
Because, I mean, that's no reason not to. If a thing's actually true, it's no reason
Right.
we can cause confusion amongst. That's how things progress, isn't it?
And that's
That
how things become more clear. You
become more clear.
elucidate.
We educate people, that's so we sort of dismiss number four, but the first three were fair dues, really. So then we started conceptualizing a consensus project, yeah, using like a Delphi methodology. And again, involving Molly and Clarissa, who they've done so much collaboration with us, just out of the love of it, really, like the rest of us,
Mm-hmm.
all kind of volunteer. Um, we invited all the clinicians, researchers, academics we could think of in the space, who were actually doing work in the space, even though it's
Mm-hmm.
not kind of acknowledged. So all the names that you could think of, like Nicola
Mm-hmm.
Vina and
Mm-hmm.
David Weiss and
Mm-hmm.
Vera Tarman and Bitten Johnson and all these people.
Mm-hmm.
Um, and we ran a series of workshops around some key questions around food addiction. And we got 40 people taking part. We got consensus, which we're really happy with, between 37 of those people on the key
Mm-hmm.
questions. And I know that one of the three has since changed their mind and would probably would have been 38, but 37's good. 37's good.
Yeah.
So the key points of consensus were there is enough evidence to um, recommend a new diagnosis. Um,
Mm-hmm.
here's the real sticky one, which is like, what are we going to call it?
Mm-hmm.
This was one that was probably the biggest debate because obviously it's a problem if we're all using different terminology.
Yeah.
So there's sugar addiction, food addiction, carbohydrate addiction, ultra processed food addiction, all of these
Mm-hmm.
terms. Um, but fortunately, those 37 people were able to get behind the term ultra processed food addiction, or in the language of the ICD and DSM, ultra processed food use disorder.
Mm-hmm.
So that the ultra processed food is the substance in a sense. Now
Yeah.
there was some dissenters, but most people could see that if we could all get behind one term, that might help us get over the line. And if we get over the line, then we can debate more about the substance.
Right.
The point that I'm most sympathetic with is Bitten's argument, really, that it's the sugar and the refined carbohydrates that are
Yeah.
soon to be sugar in the bloodstream that
Yeah.
are probably the problematic substance. But that's where we got to. Um, there was super clarity on the fact that it's it can co-occur with eating disorders, clearly, and obesity, but it can also be separate from. So you can have a primary food addiction problem without meeting the criteria for any of the eating disorders, and you can be normal or underweight and have a food addiction. So then clearly there's not this
Mm.
completely overlap with obesity, which sort of answers the second question of is food addiction explained by categories that are already in ICD?
Hmm.
What else? What else did they agree? Oh yeah, that because it's a substance use disorder, the abstinence is the mainstay of treatment. That just makes logical sense. Um, I can't remember what the other points were, but those were the kind of key ones really, which were
Right.
in
And I mean,
relationship.
that abstinence piece, I think, is one of the most critical things of like differentiating
Yes.
food addiction from anything else and like the treatment paradigms out there. I mean, that's just far and away a whole different way of approaching this issue.
Yes, exactly. And you know, one can guess that a proportion of people who are in eating disorder services, because that's the only, it's like it's that thing, isn't it? If you've only got a hammer, everything looks like a nail. So all of these people in eating disorders look like people with eating disorders. So we recommend all foods fit and blah, blah, blah. But a proportion of those people, because they don't assess for food addiction are probably primarily primary food, and they will always fail at all foods fit. I
Right.
mean, I would have failed in an eating disorder service for sure
Right.
because
Right.
you've got to be able to eat a cookie or whatever it is.
Hmm.
Um, yeah, so we did the consensus project, and then at the same time, we'd put everything together that we learned from Bitten and also from looking at the literature into a program that we thought might be good, might work really well online. And we also, again, Molly and Clarissa, how much work have they done? They collaborated with us and Charlotta and Frida in Sweden, lever sugar free, live sugar free. We all ran similar programs with people online, and we did screening questionnaires at various points pre and post the 10-week. It was weekly for 10-week treatments at 6 months and 1 year follow up, looking at the Yale Food Addiction Scale, Craved, which is our measure that we can talk about a bit more because we've done more research on that. The Warwick Edinburgh Mental Wellbeing Scale, which is a measure of mental wellbeing,
Hmm.
and yeah, so we were quite soon able to publish the pre and post data, and then we've since published the 1 year follow-up data. Um, and we're really, really happy with it. Yeah, it just shows that it is a treatable, like any addiction, it is treatable with the right treatment. Loads of people did really well. Nobody maintains abstinence perfectly from the treatment to the follow-up point,
Hmm.
but with ongoing support and you know that that kind of support of the group and at 1 year, I think we had 62% in remission from completely in remission from food addiction, and all the scores were significantly better after treatment and then maintained if
Hmm.
craved
Hmm.
YFAS and mental well-being. Uh,
Hmm.
so that was really exciting. And then there's since been a couple of other papers looking at treatment. So there's
Hmm.
Ellen Bennett in the UK
Hmm.
running a program called Liberate, and
Hmm.
she's published her outcomes. That's going to be her doctorate.
Hmm.
There's Trochalagen, um,
Hmm.
metabolic health doctor, and
Hmm.
he measured food addiction symptoms alongside what he was doing with people with their metabolic health, and he showed
Hmm.
that improving. Susan Pearce Thompson's published some data on
Hmm.
the Bright Line program.
Yeah,
Esther, good, I can never pronounce her surname.
me
Good,
neither.
Goodman's daughter.
Hmm.
Iceland has she's written up
Hmm.
her 12-step program. So yeah,
Hmm.
there's more coming out. And it kind of looks like we'd expect it to look, that actually
Hmm.
where people are encouraged to abstain from their
Hmm.
personal drug foods and eat a nutrient dense whole food diet as nature intended,
Hmm.
but they're not nutrient deficient. I think this is where a
Hmm.
lot of problems come from, is the addictive piece, but also that over time people are actually they're nutrient deficient, so their brains aren't working properly, and that makes it even harder to
Right. Right.
remain abstinent. So yeah,
And
so that's that. Oh yeah, and then we've started running the IFACC conferences, International Food Addiction, whatever conference. So we've had this consensus conference, and then last year we had the comorbidities conference. This year we're doing one online, a children's conference.
children's, wow.
Yeah, November the 14th is going to be it's going to be online, and it's going to be aimed at prevention, essentially. That if we can,
Hmm.
kids and parents not expose kids' brains to excessive amounts of sugar and processed foods, maybe we
Hmm.
can prevent some of
Right.
what's going on at the moment. And then next year we're going to be in Toronto, so 2027 will be in Toronto,
Hmm. Okay.
and
Yeah.
that's going to have a real clinical focus. We have to keep
Hmm.
thinking of things beginning with C. So I don't know where that's going to end.
And then with the response to the World Health Organization, what's
Oh
the
yes,
status of
yeah,
that right now?
yes. So we quite right. So we responded last June. We made the response to all their points with more evidence, and this
Hmm.
now really an exponential growth in the numbers of publications that are coming out. So we're able to update the research papers, and we're still waiting. So it's been 12 months. Um,
Okay.
no response. So I guess no news is good news, and it's
Okay.
given them something to think about. And in fact, people can still go in. I'll send you the link to our website, which explains if people want to support this application and support
Yeah.
this bit, you could be a member of the public, you could be a doctor, you could be some other um healthcare professional or an academic who really believes this to be the case, sees all the advantages of it being recognized. You can go in and like agree with the application, and you can put comments, and that you're still able to do that. You just have to register with the platform.
Okay.
Mm.
Cool. Great. Yeah. I'll
Yeah.
definitely put that in the episode description. I have a question about how you feel like you thrive in eating nowadays. I understand you. I don't want to put words in your mouth, so I don't know if you self-identify as carnivore or keto or like low carb or abstinent or whole food or I don't know. I'm wondering if you could fill us in on what feels peaceful for you around food lately.
Yeah. So I love how you say lately, because it's constantly evolving, isn't it? But it has been some time for me now. And I think what's happened over time is and I hear many other people this same kind of story, drifted towards carnivore.
Mm-hmm.
And I kind of eat twice a day. Have tried the whole one meal a day thing, but I think that's a bit, it makes me kind of eat too much in that one
Mm-hmm.
meal.
Mm-hmm.
Yeah, so two meals a day I eat at lunchtime and kind of early. So it was like 5 p.m. I tend to eat my
Mm-hmm.
second meal, and then
Yeah.
I'm good then, because I think what happens then is my brain and body relax because they've had the right amount of
Yeah.
protein and fat for the day. And I don't weigh and measure. I know some people do, but I've never got on well with that.
Mm-hmm.
Um, I It's fatty carnivore, I would say. So it's keto carnivore is what
Yeah,
I
so
would say.
like you eat carnivore, but in a way that facilitates nutritional ketosis.
Yeah, because I eat probably more fat than most people would do, and therefore sort of slightly less protein. Although I eat
Hmm.
enough protein, but
Yeah.
yeah. And I'm quite a salt fiend because I have low blood pressure, so I just put loads of salt on everything. I'm
Yeah.
like Dave Feldman in that way.
And do you track with using like a continuous glucose monitor or keto monitor
I have
or
done.
mojo or just do sometimes?
Yeah, I have done from time to time glucose. My glucose is like, I think I'm very insulin sensitive, so it's very boring to have a glucose meter on.
Well, it's good
Because
confirmation.
um but I do enjoy having a ketone meter, and I've been using the Sibio one.
I can't
Um,
wait to get my hands on one of those.
you're coming to the UK,
Yeah,
so
I'm gonna
I can stock up
that,
for you.
that is definitely a plan.
Yeah, so we can get them on Amazon actually now here in the UK.
That's so cool.
I mean, Abbott are doing one. I just don't have intel about when it's coming out, but they have announced it.
Yeah.
Um, and I don't. There's no reason why they wouldn't bring one out.
Hmm.
And Sibio they're doing ketone glucose now in one,
That's
which
so cool.
is very cool if you're like kind of geeky like that. So I do that from time to time, not all the time because obviously it's reasonably expensive to do it all the
Hmm.
time.
Hmm. Hmm.
Um, but it does. If I'm going away, for example, I tend to put one on because it just keeps me
Yeah. Yeah.
in the mindset that I
Right.
don't want to spoil my graph because I'm a bit of a perfectionist, so I need it. I need ketones high. Um, yeah, and you do just learn stuff every time. Every time you wear one for a couple of weeks, you learn
Hmm.
something about yourself. So yeah,
Hmm.
yeah. So
Wonderful.
that's how I eat. And then we're very lucky here because we have our own sheep. So we eat our own lamb, which I love.
Is it like, do you have, is the place where the sheep are like right in your backyard, or is this like a faraway place?
Sometimes they're near, but sometimes we have to move them around to find a bit more grass.
Okay.
So quite often they are just, I could see them probably
Oh
from
my
here.
gosh, that's so cool.
They're not here right now.
Uh-huh.
And lamb is I love lamb. I think it's just
Hmm.
perfect. 'Cause it's always
Yeah.
raised on grass. It's got the good omegas and
Hmm. Hmm.
it's good and fatty if you leave it on the ground. We always leave them like we call it mutton or hogget. It's like older. Normally lambs are killed the year that they're born or the end of
Mm.
the year that they're born, but we keep them and get them good and fat and
Mm.
and they have good happy lives. So that's how we feel okay about it. And
Yeah.
also I've got a son that's a butcher and
Wow.
yeah, and he only works with local farmers, very high quality, well raised animals. Um, he hangs it and looks after it, so it's always delicious.
Oh, that sounds
I know,
wonderful.
lucky me.
Yeah, lucky you.
Yeah.
Well, it's
So that
been,
yeah, I was going to say that's how I eat, but obviously I've had to learn to do other things as well to kind of it's difficult actually. It's hard work, isn't it, being
yeah,
abstinent in the world that we live in, and
yeah.
particularly if you want to have a social life and go places, you can be very challenged at times. Um, it's not so hard at home because
Hmm.
it's just the two of us, and that's kind of how we eat. But I learned to exercise every day. I do that. I do a boot camp every morning, sets me up, and I
Hmm.
try and do a
Hmm.
walk at some
Hmm.
point later in the day. And then um, I like to I do a lot of knitting and crochet and that kind of thing. Keeps my hands. I'm very I think as Bitten used to say, addict brains. We've got these lively brains, haven't we? So when we're awake, we're kind of, it's all going on.
Hmm.
So try and do things like that are kind of a bit more mindful and
Hmm.
relaxing if I get the time to do it.
That's wonderful. Is there anything else that you want to share? Is there a website? I know they'll include the link for ways that people can support the progression of having food addiction recognized. But is there
Yeah.
any other website or any other resource or anything that you want to share before we wrap up?
So I'm on X. It's the only one I've really done consistently. Dr. Jen Unwin. So DrJenUnwin, all one word,
Okay.
lowercase, Jen Unwin. I've written a little book called Fork in the Road, and it's the book that I wish had existed when I was a teenager, because I would have understood it at that point if someone had explained it to me.
Yeah.
This is what sugar's doing to your brain and body, try not to have so much of it. I think I would have got that. I didn't, nobody wants to harm their brain, do they? But it covers everything that we've talked about essentially, and
Hmm.
all the profits go to the work of Food Addiction Solutions, that is one arm of the charity, the collaborative health community that Heidi's set up. All the proceeds go to the Food Addiction Solutions project. So it funds things like publishing fees for the papers. It
Hmm. Hmm.
goes towards doing events, or it keeps us going. We don't need that much money because everyone's volunteers, but sometimes you need a little bit so the money from the book goes to that, or if people want to donate, they happily can. And hopefully some people will come and join us at the online conference on the 14th of November. Or
Perfect.
and or actually we've helped out with, there's a conference in Poland on the 18th and 19th of September.
Hmm.
And Food Addiction Solutions have helped design the speaker list.
Hmm.
Um, I'll be there, but also Anne Bitten and Vera and Eric Westman and
Oh, wow.
David will be there as well. And who else? Lots of excitement. So day one is for professionals, and you can come in person. I think there are some tickets left. Or what the way that we're raising money is, they've said that any money raised by the live stream of that event on day one for the which is I mean, you wouldn't have to be a professional. You could attend as a member of the public. You'll just hear
Hmm.
lectures from those people.
Hmm.
Um, all the money from that will go to the charity.
Wow.
Yeah. So if people want to live stream that, I should send you the link to that
Okay.
actually, so that,
Perfect.
because that would be a great way to support us, and you'll hear the amazing Bitten and the amazing Vera talking
Yeah.
about all their fantastic work.
That's so awesome. There's so much exciting things going on, and it's just amazing. You're at the forefront of all of this. You're involved in just all this amazing research and activism around food addiction. So thanks for sharing your insider perspective on everything and giving us the latest on what's going on, and also sharing some of your personal history and how you're so passionate about hope is such a really unique different facet about you that I didn't know about. So thanks so much for being here, Jen.
You're welcome. I enjoyed it.